Hey, CEimpact subscribers, welcome to the Game Changers Clinical Conversations podcast. I'm your host, Josh Kinsey, and as always, I'm super excited about our conversation today. Tapering antidepressants is a delicate process that requires careful planning to ensure patient safety and minimize withdrawal symptoms. In this episode, we'll cover the latest updates on antidepressant therapies, discuss best practices for tapering, and highlight how pharmacists can guide patients through this critical phase of their mental health journey. It's so great to have Sarah Grady with us for this episode. It's good to see you, Sarah.
Nice to see you, Josh.
Thanks again for taking time out of your schedule. I know that the semester just started up, so I appreciate you spending this afternoon with us. Thank you. For our learners, Sarah, that are not familiar with you, go ahead and take a couple of minutes to introduce yourself. Tell us a little bit about your practice site and maybe why you are passionate about today's topic.
Hello, everyone. It's wonderful to be with you this afternoon. My practice site is Broadlawns Medical Center in Des Moines, Iowa, the county hospital. I have many patients that take antidepressants for any number of reasons, including depression, anxiety, insomnia, pain conditions. So I talk with patients each and every day, have a lot of questions and a lot of discussion about antidepressants. So very passionate about this topic today in particular.
Yeah, awesome. And Sarah's being a little modest. She's just in general very knowledgeable in this whole space of psych and therapy and everything. So I would be remiss if I just made you think that she was an expert in antidepressants. She's an expert in a lot of that space. So thanks again for spending your day with us. So let's jump in. I always like to lay the foundation for our listeners. So let's just review briefly, Sarah, if you don't mind, some of the common classes in antidepressants and maybe just briefly touch on their mechanism of action and just kind of their place in therapy right now.
Absolutely. I think all of us are most familiar with the SSRIs. We obviously have 6. Their primary mechanism of action is serotonin reuptake inhibition. But beyond that, they do have different secondary mechanisms of action. And most of them have different structures, with the exception of citalopram and escitalopram, which are enantiomers of one another. Then we have the SNRIs. They have serotonin and norepinephrine reuptake inhibition. Our most common one that we see there in practice is going to be venlafaxine and also duloxetine. Then we have bupropion, which doesn't have serotonin reuptake inhibition, but has dopamine reuptake inhibition and norepinephrine reuptake inhibition. And then we have mirtazapine, which increases serotonin and norepinephrine in the synaptic cleft, but not through reuptake inhibition. And so I want to highlight those last 2, bupropion and mirtazapine, because they do not have serotonin reuptake inhibition. So that may come into play a little bit when we talk about today's topic regarding tapering antidepressants.
That's great. That's a great call out. So tell us why that connection exists then. So obviously the tapering is because of serotonin reuptake, I assume, or because of serotonin. So maybe talk a little bit about that.
Yeah, so we think that antidepressants that may have a higher risk of antidepressant discontinuation syndrome include those that have serotonin reuptake inhibition specifically. Also those that have shorter half-lives. So you remember, we all know that something like fluoxetine, while it does have serotonin reuptake inhibition as its primary mechanism of action, it has a long half-life. So we may not have to taper that one as much as some of the others.
Gotcha. Okay, that's great. That's a great reminder. It's been a while since I sat in the classroom for talking about SSRIs, so definitely a great reminder there. So let's then, as we're talking about tapering, let's go ahead and talk about why is that a topic for us to talk about? What are the risks of abrupt discontinuation and the impact on our patients' quality of life and their outcomes?
Yes, a couple of risks. First and foremost, if someone has been taking an antidepressant longer than 6 weeks, And they may have what we call an antidepressant discontinuation syndrome, otherwise known as antidepressant withdrawal. And I know that all of you in the pharmacies, you have had shifts where patients have been telling you about some of these symptoms, not knowing what they are, but you know what they are. You've heard people describe them to you. So things like flu-like symptoms, insomnia, anxiety, mood changes, brain zaps, electrical shocks. You've heard lots of these things, lots of these reports from your patients. So that's first and foremost an issue. A second issue would be if we abruptly stop the antidepressant too quickly, any one of them, what we are actually taking the antidepressant for, symptoms of that condition may return, whether it's depression, anxiety, insomnia, pain.
Mm-hmm.
So we definitely want to educate our patients that if they at any point want to stop their antidepressant, they really need to contact their provider first for a specific schedule.
That's great. And just to go back and reiterate something, I think it's key. You said that anyone who's been on an antidepressant for 6 weeks, like that is kind of our, I mean, that to me is not that long. So even just 6 weeks, we could see these issues if they have abrupt discontinuation, right?
Yes. So 6 weeks is, on the shorter end. That would probably most likely apply to agents that have serotonin reuptake inhibition plus short half-lives.
Okay.
So things like paroxetine, fluvoxamine, not fluoxetine. Remember, fluoxetine's got the long half-life.
Okay.
Venlafaxine, maybe desvenlafaxine as well. So, but yes, people that are real sensitive to discontinuation syndrome, they've been taking their medication as prescribed every day for as little as 6 weeks. They're on a shorter half-life agent that has serotonin reuptake inhibition as a mechanism. They may indeed see some discontinuation symptoms.
Yeah. And I think that's key because, to me at least, I guess I've always kind of thought that we're going to see these issues in abrupt discontinuation that like they've been on it for 5 years and then they just decide they don't want, they're better and they don't need it anymore and they stop it. And like, that's where we're going to have the issue. But something in as little as 6 weeks, like that could still be the time when someone's deciding whether or not they like it and want to take it, And so I think that brings us to our next point, which is one of the key things for us as pharmacists to do is make sure that we're educating the patients about that. And the fact that, because I know we always usually say, give it at least 2 weeks to see if if it's going to work, like it may take that long, but also realizing that in just as quick as 6 weeks, you can't just stop it if you decide you don't like it. So I think that's something really important to talk about. So with that, let's discuss like what are some of those talking points that we as pharmacists should have to kind of set up. We'll talk specifically in a minute about, setting the schedules and discussing that, but like setting up the discussion when patients are getting an antidepressant for the first time, what are some of the things we need to say so that we're making them aware of it, but not scaring them,
Yeah, absolutely. Wonderful question. I think some key points to touch on in any setting when someone is starting an antidepressant for the first time is number one, we want to review that average time course to therapeutic benefit, as you mentioned and alluded to already, Josh. The second thing we want to tell them about is maybe some common side effects. So if it's an SSRI, they may have a stomach upset, they may have sleep disturbances initially, they may have sexual side effects as well. And then I always add in my initial counseling of an antidepressant is, if you have been taking this for a while, and you want to stop the medication, it is vital that you speak with your provider for a person-specific tapering schedule. Mm-hmm. Because depending on which antidepressant it is, people can certainly have those withdrawal effects.
Quickly. Yeah. Very interesting. Okay. So let's jump into then, I can tell you so many times when practicing, how many patients would say, either I've been told I don't have to take it anymore, or I've decided I don't want to take it anymore. I think I'm better, whatever. I remember you telling me I couldn't just stop it, so help me. How do I get off of it? So let's spend the next few minutes talking about tapering schedules. Like, how do they come about? You mentioned that they're individualized, so I think that's something key. But let's just in general talk about that. And is that something that we as pharmacists should be doing, or should we be? Are we capable? I think we're equipped for that, but I'll let you as the expert tell me. So let's just kind of talk about that for a little bit.
Yeah, I think pharmacists are capable of many things, this being one of them. But first and foremost, I think it's important for us to let our patients know, just kind of briefly review what could happen if they abruptly stop their respective agent. And again, depending on if it has serotonin reuptake inhibition or not, and depending on the half-life, will guide maybe the severity, I guess, of symptoms. But I think it's just first and foremost important to educate our patients about what those symptoms may look like, number
Sure.
one, and number two, to also remind them that whatever they're taking that agent for, symptoms of that condition may return.
Mm-hmm.
So education on that piece. Third, we do want to loop their provider in on this discussion because we will need a person-specific schedule. And what does that look like? It depends on a couple things that we've talked about already. Obviously, if our drug has serotonin reuptake inhibition, it's got a shorter half-life. Something like paroxetine, fluvoxamine, venlafaxine, desvenlafaxine, even duloxetine. We definitely want to taper those. So mechanism is the first thing we look at. Also, any antidepressant agent that has anticholinergic properties. If we abruptly stop an anticholinergic drug, we can have cholinergic type side effects. So that could be present with something like paroxetine as well as TCAs. So looking at mechanism first, looking at half-life second, how long they've been on the drug. So you gave the example of someone that had been on it for several years. If somebody has been on something for several years, we want to take that into account. If their dose is high, if they're at maximum daily dose, we want to take that into account as well. The other question I ask people that we don't think about sometimes is I'll just ask them, hey, we're all busy. Have you ever missed a dose of your venlafaxine or your paroxetine? And they'll say, well, yes, I have, because I'm a human being and I'm going to miss a dose here and there.
Right.
And I will say, what happened? And in the case of something like paroxetine or venlafaxine, they usually tell me, oh, I felt weird. I didn't sleep well, So knowing what they had experienced missing a couple doses, you can bring that in as well. Okay, so remember how you felt. This is why we really don't want to stop this abruptly. We need to taper you over a certain specified amount of time. So, longer they've been on the drug, the higher the dose, especially if it has serotonin reuptake inhibition, has anticholinergic effects, and they've had experienced withdrawal symptoms and missing a few doses. Depending on the answers to all those questions, that will kind of target what kind of tapering regimen you want to use.
Okay.
Now, Josh, the interesting thing is that this may happen with some pharmacists because it happens to me, probably on a daily basis. The patient, is switching or, wants to get off the drug. So you call the provider, you guys are having a conversation. The provider will ask you, the pharmacist, potentially, how quickly can I taper?
Exactly.
And so that's why you want to maybe have those answers already. What's the mechanism of the drug? How long they've been on it? How high their dose has been? you as the pharmacist will have the pills or capsules strength. So you can tell, can we cut these? Can we fourth these? All these things the
Cut down the
providers are
different
going to
dose.
be
Yeah.
asking you, the
Hmm.
pharmacist.
Yep.
And so the good news is pharmacists can get really involved with this this
Yeah.
individualized, personalized process. That's the good news. The challenging news is that there's not a one size fits all, and every guideline says something different.
Mm.
So just to give you some examples, we can look at the American Psychiatric Association guidelines on this topic, and they just say taper over several weeks to a longer period of time, and they don't specifically give you a time. Another set of guidelines, the British Association for Psychopharmacology, they say taper 4 weeks to several months. So
I love the use of several in both of those. That
it's
doesn't have
very,
an exact
yeah,
definition at all.
yeah, very open to interpretation,
Yeah.
obviously. So again, that's why it's important as you, the pharmacist, to have all those answers. You know, what's the mechanism? What capsules or tablets do I have? Can I half those? Can I third those? Can I quarter those? I know that's not ideal, but you know, that's something we'll maybe have to work with. We also find that going dropping down a dose kind of on a weekly basis might be easier for somebody, you
Sure.
know.
Yeah.
So really just kind of have to personalize the regimen. And yeah, this there, like I said, the guidance is very wide all over the literature. The take home point is not a good idea to stop something abruptly unless, you know, one of our patients is having a pretty serious side effect or going
Reaction.
into
Yeah.
anaphylactic shock or something
Sure.
along those lines.
Sure. So would you say, and I'm not going to pinpoint you into like giving a week because giving a number of weeks, but it sounds like the minimum is at least 4 weeks. Like, I mean, this therapy needs to continue or discontinue over at least 4 weeks of time. Is that accurate to assume?
That's what I'm finding in a lot of the guidelines as far as what is written. Now, again, that's going to depend to some degree how long they've been on it and
Sure.
how high
Sure.
their dose is.
Right.
So we talked in the beginning of the podcast about, oh, hey, maybe somebody does want to get off of something at 6 to 8 weeks. You know, like they don't feel it's working at all. They haven't seen a decrease in any of their symptoms of depression, or they're just having some side effects they're not willing to have.
Sure.
Well, obviously, if depending on what the drug is, but you know, if they've been on it 6 to 8 weeks, we could probably taper off much quicker. You know,
Then 4 weeks. Yeah.
probably over the course of a week. You
Sure.
know, maybe two, maybe, you know, 1 to 2 weeks if it's something like paroxetine, and that's that specific example. But if they're on like fluoxetine, something with a long half-life, even though it has serotonin reuptake inhibition, if you've only been taking it, you know, for 6 to 8 weeks, it's probably
Taper a
just
little
going to
faster.
self-taper, you
Yeah.
know. So you may not even need to taper that one off
Okay.
necessarily.
Okay. But if for longer term use, the minimum is probably around 4 weeks.
Yes, I would say, you know, if we step back more broadly and think about, you know, let's say someone is diagnosed with depression and they get placed on an antidepressant, and then the guidelines say, you know, most guidelines say if it is working for you, you want to stay on it for a minimum of 6 to 12 months.
Mm-hmm.
Okay. So let's say, you know, we are on an antidepressant for about a year, and we're doing okay. It's our first episode. We don't have a family history. Our stressors are mild. I'm not sure who has mild stressors in life, but I'm sure there's somebody out there that does.
Really?
But you know, you get the point.
Yeah.
Not super stressful time in one's life.
Right.
You know, then if somebody's on something for about a year, I would say, again, depending on what the agent is, its mechanism,
Sure.
yeah, I would say probably taper over the course of 4 weeks.
Yeah. Now, so we talked about, well, a couple of things I wanted to point out. I think it's really important to remember that because you're talking about how, you know, let's say that I'm making up random numbers right now, but let's say that something is a 300 milligram. It also comes in 150 milligram and a 50 milligram. Then, potentially we're going to need new prescriptions for those, right? If we're
Yes.
changing the actual dose. So that's another
Right.
reason to make sure that the provider is looped in.
Yes.
In general, they should already be looped in because we want their opinion and their feedback. But
Right.
that's another reason is, we're going to probably need new prescriptions to be able to process those. Um,
Absolutely.
but the other thing I wanted to mention, so that was one thing. And then when we were talking about, the factors that affect, so the length of time and what else does like the age of the patient, does that come into play? What about their weight? Like are we, because you mentioned like if they're on like the highest dose, are they on the highest dose because it's weight based, or you know what I'm saying? Like
Hmm.
what are other factors that we could look at the patient and say, okay, well, I have an obese patient, or I have, a very frail patient or whatever. Like how would that kind of play into our decisions?
Yes, I would say I would kind of describe those as maybe special populations.
Okay,
So
sure.
anytime we have special populations, we probably want to go even more slowly.
Mm,
So, if you have an older adult, probably want to go a little bit more slowly compared to middle age adult.
sure. Sure. One other thing too with we were talking about how they might be taking it for depression or for pain or for whatever, if and how it's important to make sure they realize that those symptoms, those issues could return. Like if someone is taking, say, duloxetine for their pain in their back or their legs because of diabetes or whatever, or something else that they have, like are we anything special there? Like, do we need to also factor in the fact of like other medications being affected? I guess I'm just trying to think of, is there a longer reach for, or a bigger issue if we're discontinuing this therapy?
Yeah, there could be a multitude of other issues, right? If we just step back and think of the symptoms of discontinuation syndrome itself, I'm thinking like the GI issues.
Sure.
We have potentially we have patients that already have gastric reflux, peptic ulcer disease. We already have maybe patients that have diabetes and have a neuropathy, so we're giving them additional tingling sensations that isn't pleasant. It can, just contribute to, I think, lots of other potentially medical and mental health
Mm,
issues.
sure.
So I have found over time, just working with people that are taking antidepressants, coming on them, coming off of them, I feel like slower, if possible, slower is better.
Is better. Yeah.
If
Yeah.
possible. Now, there's always, some exceptions to that. Again, the exception I gave, if somebody's been on it 6 to 8 weeks,
Sure.
they're not liking the side effects, that's a whole different story,
Sure.
because sometimes the side effects might be worse than some of the discontinuation
Right.
symptoms. So there's a lot we have to factor in.
Yep.
But
Yeah.
really, slower is better. A lot of these symptoms can be minimized just by a slower taper.
Yeah. This is all just such good information, because something as simple as, you know, the question from the patient of, I want to get off of this because of A, B, or C, whatever. And can you help me? And I remember in that space being like, yeah, sure, let's figure it out. And quite honestly, like, I don't know that I probably asked some of those questions, just in general, because as
Mhm.
come up in conversation about like, making the plan. But to hear these specific things, that all of these things we need to consider with something as simple as coming off a med, like I think it's eye opening, and it should be for us as pharmacists, because this is something that we really can do, and it's very important in the outcome for our patient, in their quality of life and everything. So yeah,
Mhm.
this is a great episode. I say that every time, but never fails. So that's great. Uh, so let's talk then a little bit about just again, I want to reiterate the importance of setting the stage. So
Mhm.
we need to make sure that we are relaying this to our patients, that there could be a problem if you stopped abruptly. So just reiterating the importance of initial consultation for antidepressants. And, I know we talked about it earlier, but so people don't have to rewind and listen to it again, just to remind us, like, what are those key things we need to do when someone is starting an antidepressant, setting up the stage for please come to me if you decide you want to stop, like, to make sure that they're on the same page.
Yeah, absolutely. Yeah, and you just add it into your repertoire, because I know everyone is discussing average time course to therapeutic benefit,
Yep.
discussing those common side effects that may occur before you even get to therapeutic benefit, unfortunately, and how to manage those. And then I always tell people, look, not a good idea to stop this abruptly. These things have been reported. If for any reason you want to discontinue treatment, please contact your provider, because, based on your individual person characteristics, I just tell them a special kind of tapering regimen may
Be
need to be
required.
developed.
Yeah, yeah. And when you say contact your provider, we, as pharmacists, we can be that initial contact, right? Because then we can
Absolutely.
loop in the other
Yep.
person who may have prescribed it, or whatever caregiver is actually writing the prescriptions
Hmm.
for that. So yeah,
Absolutely. Absolutely. Because like I said, particularly pharmacists that, work with or serve a lot of communities with primary care physicians, you can certainly call them, but a lot of times they're going to ask you, okay,
yeah.
what pills do they have? What do you recommend?
They're going to
So,
immediately say, "You're the medication expert. Help me." So yeah, yeah. So one of the last thing to do before we run out of time and get wrapped up for the day is, and there may not be anything in this space, but if there's anything you can think of, like, are there certain, not that we would ever stereotype at all, but are there certain signs that we should look for in patients who are starting antidepressants where we would think they seem like someone who might abruptly stop? I really want to make sure I'm talking about this and how it can be dangerous. Like, are there any things that we need to look for to, we should be doing those counseling talks with everyone, but are there certain populations or drugs or anything you can think of, just to kind of, again, make it easier for us as we're counseling and talking, to make sure that we're covering the right things for the right people?
yeah, I think the first thing that kind of pops into my mind is anyone that seems to either voice or look like they are just uncomfortable with
With the process.
taking the
Hmm.
drug.
Sure,
They
sure.
either voice that, or they look uncomfortable,
Or say
or
something like, "I still haven't decided if I'm going to do this or not."
yes,
Yeah, yeah,
yeah,
yeah.
I don't know. My friend takes these and I'm not so sure,
Sure.
so just, I think that's kind of the characteristic that really sticks out at me. I don't know that there's a specific age or gender or anything
Sure.
like that. Just how does someone look? Are they not asking you any questions, or are they asking you too many questions?
Hmm. Hmm.
Are they are they too worried about, but basically that discomfort, either
Sure.
verbal or nonverbal, that people express. Also, I know a lot of patients that you take care of. So, their previous history. Do they
Hmm.
have a history of abruptly stopping other medications,
Hmm.
not necessarily antidepressants, but just,
In general.
do they abruptly stop antihypertensives or statins or antibiotics? Do they kind of have a personal history of that
Yeah.
they mention to you, or they don't ever come back for refills?
Right. Or
What's the refill?
you've noticed with adherence issues. Yeah.
Yeah.
Yeah. Yeah.
Or they tell you, they just tell you, like, look, um, it's hard for me to remember to take medication every day. If that's the case and you see a script for a shorter acting SSRI, maybe they would be a better candidate for a longer acting
Good talk.
SSRI or
Yeah.
a different
Yeah.
antidepressant. altogether that doesn't have major SRI characteristics.
Yeah, no, that's exactly what I was fishing for. I don't know if I set up the question right, but you answered it correctly. That's what I was looking for. Is like who should we really be worried about with abrupt discontinuation? So
Mhm.
I think that was exactly what I was looking for. So thank you. Well, we're almost out of time. So before we wrap up, I always like to have our guest kind of summarize the topic for us. Sarah, tell us what the game changer is here. Like, the topic for the day is tapering antidepressants, but what's the take home point for our listeners?
Yeah, number one, I feel what we do best: education, education, education. Let's
Mhm.
talk to our patients. Let's let them know at that initial antidepressant counseling session, not a good idea to stop this abruptly. You may not feel so well for a couple days to a couple weeks. I can, in conjunction with your provider, we can work together to safely, get you off of this medication. So I think education is the biggest piece, and then also just remembering when you get those questions, if and when you get the questions from the doctors, how do I taper? Think about the half-life of the drug, or we can look it up if we don't remember. Um, Most antidepressants have serotonin reuptake inhibition, but not all.
Mhm.
That's a factor as well. If they've been on a medication for several years and their dose is higher, we definitely want to have a longer taper for that one,
Mhm.
as opposed to a patient that's on a low dose and has only been on something for a couple of months.
Sure, sure. That's great. So if I could summarize in three small words, it would be educate. Well, maybe it's four words: educate, ask questions, and then collaborate. And
Yes.
collaboration is the individualized plan with the patient included, because again, as with any treatment plan that we come up with, the patient has to be on board. So if we're going to
Mhm,
go back and say, you're going to have to taper this over 8 weeks, they need to be on board with that, and
mhm.
it needs to be something that they're going to buy into as well. So yeah. Well, Sarah, thank you so much. This was such a great topic. I think it's really an important one. We see a lot of, it's probably one of the most popular classes of medications that we see in pharmacy. And so this question, I know every listener out there has had this multiple times. And so it's important to make sure that we understand our role and what we can do as a pharmacist. So thank you so much for your time today, Sarah.
Thank you for having me.
Yeah. If you're a CE Plan subscriber, be sure to claim your CE credit for the episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.